Good morning, everyone, and welcome to the second in our series of webinars focusing on National Radon Action Week. My name is Sarah Kirby, and I'm a professor at NC State, and I'm the assistant director for NC State Cooperative Extension. And we will serve as your technical and platform host today. Our real host and the brainchild behind this webinar series is Philip Gibson with the NC Radon program. He's a radon specialist. I'm going to turn it over to him for further introductions, and then we'll get started on the webinar. So welcome.
Thank you, Dr. Kirby. And thank you once again for sharing your time and expertise in making the webinar technology of North Carolina State University available for this important series. Really appreciate it. To everyone, thank you for your participation. I wanted to remind you that this session is being recorded and will later be made available through ncradon.org. That's the North Carolina Radon website. I want to remind everyone that there's a number of folks that stated in their registration that they have not tested their home for radon and may not know how to do so. So feel free to give me a call and an email, but there are free radon test kits available in most every state across the country. I know for North Carolina, we still have test kits available, so you can go to our website and order one for free. I want to point out the support that we've had in reaching various target audiences for this and the other webinars. They are represented on this slide. And while the North Carolina program, we began this process with the goal of reaching North Carolina audiences, we realized quickly that the subject matter and the caliber of professionals presenting were important to others outside of North Carolina. So I'm glad to see that that in fact is the case, that there are those of you outside of North Carolina who find this of value. So our speaker today is Dr. Bill Field. Dr. Field has been actively involved in radon-related research for over 30 years. He is a professor at the University of Iowa's College of Public Health with appointments in the Department of Occupational and Environmental Health and Department of Epidemiology. Dr. Field received a PhD in preventative medicine from the College of Medicine at the University of Iowa. And Dr. Field was the lead author of the comprehensive Iowa radon lung cancer epidemiological study, which, you know, sidebar, everyone should take a look at that, try to get a copy of that once that report is something that Dr. Field could provide. And he's been actively involved in both the North American and global radon epidemiological pooling efforts, some of which were discussed by Dr. Samet last week. In 2009, his keynote address at the International Radon Meetings launched the World Health Organization's Handbook on Indoor Radon, a public health perspective on behalf of the World Health Organization's International Radon Project. Dr. Field served as a member of the US EPA's Science Advisory Board between 2009 and 2018, and he currently serves as a presidential appointee on the Center for Disease Control's Advisory Board on Radiation and Worker Health. I'd like you to join me in welcoming Dr. Bill Field.
Thank you very much, Phil, for that kind introduction and for all the work that you do there at the North Carolina Department of Health. And I also want to thank Sarah Kirby at the Extension Agency there for, she put in her technical and platform hosting. Without that, I wouldn't know what I was doing. So I appreciate that very much. So as you can see from the first slide here, what I want to talk about are radon resources for health care providers. And as part of that, I want to sort of highlight the healthcare provider guide that we updated that hadn't been updated since 1993. So I think it was about due, and we got that out about 1.5 years ago, and I'll give you some information about that. But again, I'd like to thank you for signing up for the webinar. And after the webinar, if there's anything I can do to help with your outreach activities, you know, feel free to contact me directly. I'd love to do that. While we talk about healthcare provider education, the real goal is to educate the public and get them to perform radon testing and mitigation as appropriate. But certainly, medical providers are important component to getting the public to test. Very often, for most folks in the public, medical providers are probably the sole scientist and reputable source of information they rely on for health-related decisions. So you can see how it fits in here within the continuum of all the different inputs we have to educate the public. So what I want to talk about today, I want to highlight some of the focus group findings regarding the healthcare providers' lack of knowledge or misperceptions about radon. Provide insights into other focus group findings regarding healthcare providers' knowledge that may impact educational efforts in regard to radon. And these may be useful, providing some perhaps pathway to help educate healthcare professionals as far as perhaps biases that they may have, and provide a brief overview of the Radon Guide for healthcare providers, briefly discuss some other resources that we're working to develop for healthcare providers. So when we first thought about developing such a guide, I thought it was really important to reach out to a lot of different stakeholders. So we convened focus groups here in the region and then different parts of the United States. And the focus groups were composed primarily primary care providers, physicians, physicians assistants, and nurse practitioners. And very often when you have an encounter at a clinic, you spend more time with the support staff than you do with a physician. So it was really important, we thought, to also provide some education for the support staff as well and get some inputs as far as their perspectives into radon. So one of the things I want to talk about, a few awareness issues that we have with healthcare providers, and then some misperceptions. So most of the providers that we dealt with, they understood that radon is estimated to cause about 21,000 lung cancer deaths per year in the United States. And we've had that information for a long time. It's sort of what we relied on as the central estimate for the risk. But what they weren't aware of is that protracted exposure to radon is one of the top 10 causes of cancer mortality in the United States. So if you look at this is projected for 2020. I just updated this recently and I have to go back and check my numbers, but I think these are fairly accurate. And this information came from Cancer, a journal for clinicians that was just put out a few days ago. And in there, you probably have seen some news articles about the reduction in cancer rates overall in the United States, and that was really driven by a decrease in lung cancer. When I was performing studies in Iowa, the estimated U.S. death rate was about 160,000 or so, and then it's been declining since. The majority of that is due to reduction in smoking rates. But if you look at, here's the leading causes of cancer death in the United States. And if you would treat radon as its own disease category, you can see radon-induced lung cancer is one of the top 10 causes of cancer mortality overall. Very often people compare radon-induced lung cancers, this 21,000, to the total number of deaths, but it's sort of an erroneous comparison. If you compare most other causes of cancer to smoking, they pale in comparison. So if you look at radon, it's really one of the leading causes of cancer death in the United States. Another issue with perception, as I mentioned, healthcare providers were aware of the 21,000, but what they didn't realize was lung cancer in never smokers is one of the top 10 leading causes of cancer mortality in the United States as well. So what we see here, and this is estimates from 2016, and you can see back in 2016, the total mortality was even up there compared to what I just showed you in the previous slides. But if you look at lung cancer in never smokers, about 20,000 people die each year from lung cancer who never smoked, and that was eye-opening to them. The other misperception, and this was probably one of the greatest misperceptions, is the healthcare providers that we interacted with in the focus groups thought that the majority of the radiogenic dose delivered to the lung was actually from the radon gas. they weren't aware it was actually from the radon decay products that get released from the radon gas and then are airborne within a room. So some of these are attached, as you know, and some are unattached. And you breathe in these solid radioactive decay products, and they continue to disintegrate by alpha decay, especially polonium-218 and 214. And I'd say maybe 10% of the healthcare providers that we interacted with, some knew that it was the radon decay products causing the lung cancer, but they certainly weren't aware it was primarily these two alpha producing radon decay products. The other really big misperception that we ran into, if you look at this little chart here, here's the EPA action level of 4 picocuries per liter, World Health Organization guidance of 2.7. What we generally see in homes, about 1.3. And then this is the generally attributed outdoor radon concentration, although it does vary. I mean, in Iowa, it's more like 0.6, but we have locations in Iowa where the year-round concentrations are 1 outdoors. But if you look at this 0.4 outdoors, and you look at what the EPA action level was set at, it's not a health-based guideline. And many physicians and other healthcare providers thought that everything, if you have 4.1, you should probably get it fixed. If you have 3.9, you're safe. So you see it a lot of times in articles that are written that the radon concentrations were safe if they're 3.9. But if we treated radon like we treat other environmental carcinogens that are regulated by the US EPA, we would have to reduce to have a true health-based guideline, we'd have to reduce this health-based EPA action level down below 0.4. It'd have to be something more in the order of 0.05. So it just shows you that this is not a health-based guideline, and it was really put together as a reasonable estimate at the time of what people thought houses could be mitigated below. So I think it's really good to keep in mind that with its 4 picocuries per liter, 2/3 of the radon-induced lung cancers actually occur below this action level. The other risk perceptions, mortality risk estimates are based on older studies of miners exposed to high levels of radon gas. That's certainly true that the EPA estimates that we use to derive the 21,000, as Dr. Samet talked about last week, the basis for that 21,000 was an EPA assessment of risks of radon at homes, but it was generated from the miner-based data. So that was the information feeding into it. And a lot of criticisms that we heard in the pilot studies was how can you extrapolate, and in fact it's actually interpolate information from these miner-based data to people living in homes. We know that in mines the depositional environment is very different, particle loads very different, attachment rates very different, breathing's very different, mostly a male population, higher exposures over a shorter period of time. But what they weren't aware of is that there's all these case control studies that have been performed of people actually living in their homes. So that was all new to them. So we have direct evidence now that Dr. Samet didn't talk as much about last week, but there's a really substantial body of evidence from the case control studies. I'll talk a bit more later. There's also this opinion that there's a lack of consensus. And some of the lack of consensus, I think that perception was generated by many of the ecological studies that were performed. And when I say ecological, I mean where you take county lung cancer rates and then you take average county radon concentrations and you try to do a correlation. And what we know is that county rates do a very poor job of predicting radon-induced lung cancers. So you just really have to adjust for smoking in those counties in homes that generally where individuals with lower socioeconomic status live. The radon so a bit lower in those. So and those folks with lower socioeconomic status historically have smoked more. So there's a lot of interactions that have to be considered in epidemiology studies. And when you do these studies like we did in the case control studies, you really need individual radon measurements. So these studies have been done all over the world. And from the miner-based data, there's a lot of consensus. As Dr. Salmon talked about, the minor-based data had a whole review from the National Academy of Science that helped generate the 21,000 risk estimate. In fact, what they estimated was about 18,000, but then the EPA updated that with updated demographic information from 1995 to come up with that risk estimate. But we have a consensus with the World Health Organization, and that was really impressive. When we went to Geneva, and you have scientists we had scientists there for the first meeting for about 25 different countries. And if you think about how things are today, trying to find consensus it's a pretty hard thing to do. But in this room of 25 scientists from all these different countries, we were able to come up on the first day with a consensus statement that radon is indeed an important environmental carcinogen and workplace carcinogen. So there's a lot of consensus out there, but unfortunately that doesn't always get expressed in the mainstream media. As I mentioned before, healthcare providers were not aware of the more recent case control residential studies that have been performed. And this is from the Healthcare Providers Guide. And we talk about 7 of the more scientifically rigorous studies were performed in North America, 13 in Europe. And all these, 19 out of 22 of these case control studies reported increased lung cancer risk, not just at the EPA's action level, but at the World Health Organization's radon guidance of 2.7. So if you see 19 out of 22 studies showing increased risk at 2.7, which is obviously below the EPA action level, the chance of that occurring is, if it was just by random chance, to have 19 out of 22 case control studies reporting an increased risk, is less than 1 in 1,000. From the individual studies, there's a large effort done to actually put in the late 1990s and early 2000s to pool these studies. And when we say pool the studies, you probably have heard of meta-analysis, where you take a group of studies and you look at the summary risk estimates and you come up with an overall risk. With these pooled analyses for both North America and Europe, what we did was we pulled the information from each study. So we took the individual data and did a reanalysis. We performed what they call sensitivity analysis to see if we make an assumption that these risks or these radon exposures were off by this much, how does that change the risk estimate? And what we found was that the risk estimates from these pooled analyses were very much in line with what was projected from the minor-based data that Dr. Salmon talked about. So one of the things for causality that you look at in epidemiology is consensus among studies. And we have a lot of consensus between these studies, and we also have consensus with the minor-based data. Another perception, they frequently state, we see very few patients in our clinic. And this is probably one that I've been getting for about 20 years when I work with healthcare providers, but it also showed up in the focus groups, that we just don't see that many people coming into our clinic that have lung cancer and never smoked. And if you look how the percent of smokers in the past, there was a pretty high percentage of people that smoked over 100 cigarettes, which is considered a smoker at some time in their life. So it's not surprising that folks are coming in with lung cancer that smoke, since smoking causes the majority of them. But what a lot of times people don't realize, and I mentioned this before, if treated on its own disease category, individuals that never smoked developing lung cancer is one of our top 10 causes of cancer mortality in the United States. So I can see how they see most people, they've smoked in the past, but there's a fairly substantial percentage of people that never smoked developing lung cancer. And it seems like, especially in women, we're seeing more and more women who never smoked developing lung cancer. And if you look at that, this is what I talked about before. This is based on 2016, and again, we have approximately 20,000 people that develop lung cancer that never smoked, and that would rate in one of the top 10 causes of cancer mortality. Other focus group findings were that very few of the providers have received any training in medical school or elsewhere in their residency about radon. And in fact, that's not unusual. If you look at surveys of training in medical schools, they don't receive information on radon, and a lot of environmental and occupational hazards is a topic that isn't always looked at or examined during medical school. And one of the things we've been trying to do is to get information out there on occupational and environmental causes of lung cancer in journals that healthcare providers read, get some updated information. What we did before we published this review and looked really what was out there, and there was very little information out there concerning what are the major impacts in medical journals of lung cancer overall. And then we developed a chapter for Parkes Occupational Lung Disorders. And in this chapter that we wrote, Parkes is the primary textbook used for pulmonary physicians out there, and also used by a lot of general physicians on occupational lung disorders. And we really wanted to get a chapter within occupational lung disorders that highlighted radon as far as its relative risk compared to other concerns or other potential occupational lung carcinogens. Other findings that we had with the focus groups was that they have numerous physicians and other healthcare providers. They have numerous existing working relationships with cancer centers, coalitions, and other partners. And the nice thing about working with a cancer consortium, and this is the Cancer Consortium here at the University of Iowa, the Cancer Consortium also works with all these other partners. And once you start working with a cancer consortium, it really synergizes your ability to reach out to other partners in the area. So if you're not working with a cancer consortium in your state, I would really recommend that. Most of them have goals for radon, but once you start working with them, there's a lot of inroads to other organizations within the state or region that serves as a good conduit to reach out for educational efforts. One of the other things that arose while we were developing the Healthcare Providers Guide years ago was doctors, and we found the focus groups are very interested, obviously, in low-dose CT screening. An article came out in 2011 in the New England Journal of Medicine through the National Lung Cancer Screening Trial that showed that it's worthwhile to perform low-dose CT screening to detect radon or detect lung cancer early. And they developed through the U.S. Preventive Services Task Force recommendation statement for low-dose CT screening. So they recommend annual screening for lung cancer with low-dose CT in adults 55 to 80 who have 30-pack years smoking history and currently smoke or quit in the past 15 years. Screening should be discontinued once a person has not smoked for 15 years or develops a health problem that substantially limits life expectancy or the ability and willingness to have curative lung surgery. But what we found out was a lot of people call in and they don't meet this criteria of 30-pack years smoking history, but they're really concerned, obviously, since they called in to get low-dose CT screening about their potential to develop lung cancer. And we found that this is a really teachable moment. You already have individuals interested in what they can do to reduce lung cancer. And if we can get radon included for the individuals who don't qualify when they call in as a part of its action steps that they can take, or for people that do qualify, that radon's an actual component to activities they can take to reduce the chance of developing lung cancer, I think this as a sort of low-hanging fruit and something we focused on in the Healthcare Providers Guide. So let me just briefly talk about the guide. As I mentioned, the previous EPA guide was published in 1993, so it's been a lot of years since it's been updated. And this first came out, we first launched this about a year and a half ago. Within the Healthcare Providers Guide, we have these different topics, and these topics and the content within the topic was really driven by your interactions and focus groups. And it wasn't just an initial focus group. After we developed these different sections, we went back to some of the focus groups to get their feedback on how persuasive the information was, or just in general, was the information everything that they needed to have a preliminary background to help advocate for radon testing for their patients. The sections are: what is radon? How does radon enter a home? We obviously had to talk about radon decay products, since a lot of healthcare providers didn't know that these were the products that were causing the lung cancer. the numbers and public health impact, radon and smoking combined health risks. We know there's a synergism between smoking and radon exposure. It's synergistic but submultiplicative. And we talked about radon health risks for individuals who never smoked, which is something that they, sort of a group that they didn't consider to be that much at risk. We talked about the science behind the risk estimates. They wanted to know what are the bases, what makes up the basis to come up with estimates of risk. Then, of course, talk about radon testing and radon reduction. And in the focus groups, it was very interesting that I would say only about 15% of the people in the focus groups tested. And then after some of the focus groups, they went back and tested. I think radon testing for healthcare providers, if we can get them to test and then actually see that their homes may have elevated concentrations, they have more of a personal stake in it. Plus getting healthcare providers to test gives them background to help describe it to their patient, what testing is like, and then interpretation of the results. Other sections, sample guidance for patients regarding radon testing and mitigation, and then the role of healthcare providers and other educational resources, provide links to those, and interventions to reduce the burden of radon-related lung cancer. Just some of the content within the healthcare providers guide. Very often you see this map, and a lot of people call the map the EPA has is, where not to test. So if you're in an area with low radon concentration, as it was described, you would think, well, I'm good, I don't need to test. And what we tried was a strategy. The focus groups found it much more persuasive to list it rather than the existing way that the EPA had set it out to have a high risk, moderate risk, and enhanced risk. So even an enhanced risk gives the connotation that there's some risk to living in these areas, and you should certainly do radon testing. We updated the entry point diagram a little bit and pulled out different sources of how radon can get in the home just to highlight them. One of the focus groups concerns, the original EPA radon risk map had different denominators. As you can see here, at 20 it's 36 out of 1,000. At 4 it's 73 out of 10,000. Then they had a different denominator, and they thought this was pretty confusing and hard to interpret. So we developed in the healthcare providers, we base risk on 100,000 individuals, so its comparisons between the different radon concentrations are more understandable, but yet we still had the bottom line risk for smokers and never smokers. We also highlighted the table that I talked about previously, where it compares radon-induced lung cancer to all causes or all different subtypes of cancers. And the nice thing is, in the actual guide, if you would go to the health provider guide that's out there right now, we have estimated U.S. deaths. I think it's for 2018. This is something I just worked on a couple of days ago. So this information just came out from this journal. And the nice thing about the Healthcare Providers Guide that we can update it routinely, so it can sort of be a living document. So these are the new numbers that are going to be showing up in the guide when it gets updated. We have a pull out talking about National Comprehensive Cancer Network and documented that other agencies actually recommend screening beginning at 50 years for individuals with at least 20 pack years instead of the 30 if they have documented high radon exposure. So we highlighted that in the guidance. We talk about radon health risk if individuals never smoked. And we talk about the top 10 causes of cancer in the United States for never smokers. And we talk extensively about the science behind the risk estimates. We talk about the minor studies, and we talk about the residential studies. Talk a bit about radon testing, radon reduction methods, have resources for those, and then sample guides for use in healthcare settings. One of the things we really want to focus on, we really think has a lot of payback if we can get it instituted. It's very often when you come in to get your intake, you fill out a questionnaire, and very often you have information on there like, do you smoke? Do you have living will or advanced medical directory? Do you wear your seatbelt? all these common sense questions that are important as far as someone's health that a physician sees or other healthcare provider. But what we also want to see listed: have you tested your home for radon? Yes or no? And if they haven't, be able to provide information on radon testing. And I'm really encouraged with this. I'm getting more and more questions from healthcare providers saying, how can we, what's the best way to word this question within our intake summary that we obtain. And some systems in 3 or 4 states have gone to actually including this question in their systems that they've generated, provide services to hundreds of hospitals. So I'm really encouraged about getting this in when someone gets screened. And we talk about other educational resources at Radon Leaders, the EPA website. And then we have a website that we sent up that is specifically for healthcare providers with information. And then we thought we'd provide a checklist of interventions that healthcare providers can do to reduce the burden of radon-related lung cancer. Ask their patients if they have tested, and if not, inform them about the health risk. And for this one, we really urge healthcare providers to test first so they can share their experiences with their patients. And one of the things that you'll find, if you look at radon testing behavior in different states, healthcare providers generally have some of the highest rates of testing already. But if we can increase that so they can provide some actual input, and say, I actually tested, so I really advise you to too. Add radon testing to electronic medical records, team up with CDC-funded comprehensive cancer programs and their consortiums, provide information in offices, talk a little bit about the low-dose CT screening program, and try to incorporate a way to talk about radon if individuals aren't eligible when they call into the screening centers, and just share information to health risks and protracted exposures when you go in for a visit, when you talk with them, give them resources that they can find out more information. The guide's available at Radon Leaders. We also have an easier link. It's just breathingeasier.info website. And on that link, we have a video that we produced. And this is the person that sort of narrates. This is Chuck Lynch. He's the medical director of the Iowa Cancer Registry, MD, PhD physician. The other thing, we're trying to reach out more to medical organizations like the American Academy of Family Physicians. We recently had an editorial on radon that got out to 180,000 of their readers. These healthcare providers, frontline healthcare providers, got a lot of calls that came directly to me and different states after that was released. And this was the editorial just published in September 2018, Radon, a leading environmental cause of lung cancer. Very good response from a lot of healthcare providers around the country on the editorial. We're working with other agencies now and other professional organizations like the American Academy of Pediatrics to get a similar editorial in their journals. But a lot of times when people do searches, these things pop up, and I think they're really influential with healthcare providers. The next step that we're currently working on now, we hope to have finished by the end of the year, is to have CMEs developed for healthcare providers, nursing and physician and other allied health workers, that they can actually get credit for perhaps reading and listening to the video and then going through and answering some questions from the guide. So with that, I'm happy to take questions now if we have time, or like I said before, please feel free to contact me directly if you have follow-up questions, or if I can provide any information or resources for your efforts within the state where you work.
Great. I don't see any questions currently in the chat box, but if you have questions that you would like to ask Dr. Field, feel free to write them in the chat box and we can share. Do you see that Philip has shared in the chat box the link to the publication that Dr. Field discussed? So if you did not receive it in your email, you will have that as a link via the chat box.
And like I said, please feel free to, a question may not arise now or in the next day or so, but feel free anytime in the future to get in contact with him. I'm not going to retire for a few years yet, so I'll be available for support.
Okay, we have one question, and that is any suggestions for getting buy-in from providers that don't want to encourage testing because they serve low-income residents that don't have the money to fix or to mitigate a radon problem?
No, that's an excellent question. That's obviously the Achilles heel to radon testing. You go out and you try to get radon testing folks to test, and a lot of times they can't afford the cost of the mitigation, which then brings extra stress because now they know they have a problem. We've been trying to work with Blue Cross Blue Shield within Iowa to try to get some funds for individuals in low-cost areas. And maybe Phil, I don't know if you have any suggestions as well.
There are a number of efforts going on in North Carolina specifically, and I believe that there's other states that are doing something similar to what we're doing, which is, for us, we have the North Carolina Housing Finance Agency, and they're providing funds for those who meet poverty criteria, economic poverty criteria. There are funds available from some organizations. You may want to look at those that are foundations or funders within your state. We had a unique relationship with, or we have a unique relationship with the Lung Cancer Initiative in North Carolina, who is historically a funder to Duke Cancer and other researchers. And recently they provided $10,000 towards a community action group in Wake County towards mitigation of airborne radon, not waterborne. So there are things like that other states are doing. I know from listening, if you want to send me an email specifically for your state, I will put you in touch with your local contact. But I know that there's been some efforts also in trying to involve Department of Energy in this effort, as well as USDA.
Right, and there are federal spending accounts. If you have a federal spending account, which unfortunately a lot of low-income individuals don't have, it is an eligible expense for federal spending accounts usage.
Some additional questions that have come in is, do you know where we can find information about radon in languages other than English?
Absolutely. I'll speak to that very quickly. So the U.S. Environmental Protection Agency's website has Spanish versions of their fact sheets and others. I believe the Center for Disease Control and Prevention may also. I know absolutely the EPA does. They have an entire section of the website that does that. There's also work that Minnesota has done, and they actually have videos on how to test homes, and it's in I believe Arabic as well. So there's Spanish and maybe one other language that they're providing assistance with. But those are the two languages outside of English that I know that materials are available.
Okay.
Right, and with the Healthcare Providers Guide, we're trying to get that translated to Spanish as well. I have a Spanish version in the coming year or so.
Okay. What are the health effects of radon in water?
Phil, I can brief.
Please, you go ahead.
Okay, so in most cases, the risk is really from what's below your substructure around the basement, your foundation, penetrations. For the majority of homes, that's the source. If you have groundwater sources, not surface, but groundwater sources of radon, wells, or maybe it's a community well source, that is a potential source of radon entering the home. You need about 10,000 picocuries per liter in well water to contribute about 1 to the indoor air. So the majority of the risk is not so much from the ingestion, it's from radon becoming airborne through dishwashing or showering in a home. So I think the first step would be test your indoor air. And if you live in an area that has higher well water or groundwater concentrations, maybe that would be something worth considering as well. But that's certainly a source of radon in a home.
Okay. What is your opinion, or do you think there's a need to enhance education about environmental exposures in medical school, in the medical school curriculum?
Yes, I think that's huge, and we're working with an organization now that's involved with the training of physicians in medical schools. So we have a good dissemination of this document to that group. They've included it in their I think twice now in their monthly updates of as far as resource education. But we're hoping to work with them this coming year to develop it's sort of an online course that individuals that are in medical school or nursing school or training can also take. So that's something that is certainly in the works and a high priority.
Okay, we've got a couple more if we still have time. Do any of the state smoking cessation quit lines address radon as a risk reduction strategy to callers?
I'm not aware of any. How about you, Phil? Do you know if that's the case?
Well, I'm sorry, what was the question again?
The question was, do any smoking cessation quit lines or hotlines within the state address radon? We're trying to get it in, include it when people call in for the low dose CT screening, but I'm not sure if any quit lines address it.
So I can't speak to any other states. I know in North Carolina, since I serve on one of the subcommittees for the Cancer Control Consortium, if you will, that's been a discussion point. I don't know that it's been implemented.
Okay.
Right, but I think that's a really good question worth following up.
And here's another sort of related is, does the guide address radon testing after a lung cancer diagnosis to reduce exposure of other individuals in the patient's home?
It doesn't address that directly, but being involved with the Iowa radon study where we've had over 400 women with lung cancer and being indirectly involved with other studies, that unfortunately is when we get a lot of calls. I developed lung cancer. I never smoked. I'm worried about my family that are still living in there. It doesn't address that, but that's probably one of the highest radon testing groups, people that have developed lung cancer. That's why our participation rate is so good when we go out to people with lung cancer, even though it's a dreadful disease and they're really struggling with it. We get a higher percent of people that want to take part in the study because they're really interested in the radon, potential radon exposure to their family.
So is this statement correct? If one is exposed to high levels of radon and is a current smoker, could the risk factor of lung cancer be about 1 in 4 of about 1 in 4? Of course, it might depend on the length of time, exposure, and level of smoking. So.
Right. It could be that high depending on the radon concentrations and the amount of smoking.
Okay. All right. And then the last is a comment, and that somebody is hoping that this will be a living document, and would it be possible when it's updated to write the revised date on it?
Excellent suggestions. We will do that. We hope it will be a living document. We tried to update it last year, and there were some staff changes. The CRCPD, Council on Radiation Control Program directors, have been excellent in supporting the development. They really provide the funding to develop the guide. They had some staff changes last year, so we weren't able to get it updated last year. But as you can see, we're already updating it for 2020, and we hope to have that done within the next few months. So I think that's an excellent idea to put the revision date on it. Okay. Thanks for that.
That is the end of questions that are in the chat box. So, Philip, I'll turn it over to you and let you close us out, if you will.
Super. We have one additional new message. I don't know if that's just me or...
it may be just to you.
Maybe just me. So the final comments that I'll make is I want to thank Dr. Field for providing your expertise and your time. You are an invaluable resource to all of us at state programs, if not other places. I know that you're always the featured presenter when I attend the international conferences. So I'm thankful for your continued support and passion around this subject matter. I have sent everyone out a, go ahead and type your question. By the way, I just see somebody says, I have one more question. Please go ahead and type it. But one other final note from me would be that there are 2 more sessions this month. Those have filled, but we have now 4 new webinars that are in more technical aspects of mitigation and measurement. And I just provided the link. I'm sorry, I didn't provide the link to you, but I emailed all of you all a copy of that announcement. So feel free to go ahead and begin registering for those in February. And I'm hopeful that this session and the others coming forward are of support and help to you all in your work. Thank you all. I don't know if that question's already been submitted, but there was one more apparently.
Yeah, I don't see it yet.